Thanks so much, Rhoda, for the welcome. And we're actually 7 minutes into the time that we needed to have. So I will ask that we probably just start off. But before we go on with the introductions, I must say welcome to all of us for this evening session. And today we are going to move a bit away from the norm, and we have very interesting guests all the way from Brazil who are going to share with us the experience that they've had there in as far as COVID-19 is concerned. So, boa tarde, Burali and Ribeiro. Hope I got it right.
Boa tarde.
Boa tarde.
Good afternoon.
And good evening to everyone else who has joined in into this meeting. Before I give a chance to John to officially introduce you and the team to everyone else, we thought we would need to have this discussion as the School of Public Health, because we've been looking at the trends that the COVID-19 has been taking globally. And if you look at Brazil, is a country that is ranking very high, actually, second to the US in as far as COVID-19 is concerned. As of today, you are at just about 3.4 million compared to the US that is about 5.4 million. So it will be interesting for us to just hear from you how your experience has been, how you managed in terms of your health system's capacity, and how you've been handling the condition as it evolves. So before we proceed with the discussion, I wish to invite John. John will just do a quick introduction for all of us, and then we will have we'll give a chance to Richard to give us just a quick snip review of the discussion. Then between Rafael and Ribeiro, you will agree who goes next in as far as your presentations are concerned. So we just have a quick short presentations that will be followed by a question and answer session. So John, go ahead, please.
Okay, thank you very much, everyone, for being here. I would like to introduce our special guests today from Brazil. Both are from the University of Sao Paulo. Let me start with Dr. Rafael. So Dr. Rafael is a technical consultant at the Brazilian Ministry of Health and the Pan-African Health Organization, and the General Coordination of the Occupational Health from the Secretary of Health Surveillance, a Brazilian ministry. So he's a PhD holder. He's currently working on diverse themes related to environmental and occupational health. So he's actively involved in COVID-19 response in the Ministry of Health Brazil. So welcome very much, Dr. Rafael. The second presenter and guest from Brazil, we have Dr. Adelson Ribeiro. Dr. Adelson Ribeiro is a postdoctoral researcher at Barreto's Cancer Hospital, focusing on special analysis of epidemiological data related to cancer incidence. So he's also a member of the research center in the environmental and risk assessment and the study group of spatial analysis. So welcome very much to the session today. And I want to ask everyone to pay attention to what they have to say, and then we will have a question and answer at the end of the presentations. Dr. Richard Aya will be part of the panelists, and Dr. Richard is a senior lecturer in the School of Public Health, and he's also the Director of Science and Technology Park, Makerspace. Dr. Chris Barasa is an adjunct lecturer from the School of Public Health, and also taking an MSc in obstetrics and gynecology. So those are the panelists that we'll have today. So let me take back the session to Dr. Chris.
Thanks so much, John, for that quick introduction. Richard, maybe you could go first before we invite our guests. So kindly take the mic.
Yeah, no, I'm just eager to listen and hear, because ordinarily we'd have to travel all the way to Brazil to listen to this. So the opportunity is there. I mean, we're talking about a pandemic, which means it affects all of us right across the world. So you've highlighted the numbers, but I think more importantly is to hear what's being done and what are the lessons that we can pick up, because I think this is a period where we need to cooperate as much as possible. So the more knowledge and the more understanding we have of what the issues are, the better. So I think over to the panelists to start presenting. Thank you.
Shall I start? So many thanks, Dr. Aya, many thanks, John and Dr. Baraza, for this invitation. You're still invited to come to Brazil, but it's a good way to begin this collaboration and start this introduction, sharing our experience in Brazil, how we are dealing with the COVID-19, the main challenges we are facing at the moment, and hopefully it can help you guys to better deal with this disease in Kenya. So I will share my screen now. Can you see that?
Yes, we can. Yep.
So I'm going to talk a bit. So I'm going to talk a bit about the COVID-19 in Brazil, where we are now and where do we go. My name is Rafael Borali, as they said before, and I work currently for the Brazilian Ministry of Health. So my talk today will talk about these topics. Firstly, I will briefly introduce who we are to our colleagues in Kenya or whatever they are that doesn't know Brazil. COVID timeline, and then where we are now. Our awful, I'm going to show a bit about our awful numbers. I'm going to talk a bit about health workers and how they were impacted by the COVID-19. I'm going to present some challenges and where we are planning to go from now. So who we are? Well, Brazil is the largest country in South America. You can see in the map in your left-hand side. Is the 50th largest nation in the world. We have a population of about 200 million people, 210 million people. We have more than 5,000 municipalities, from small towns to big, massive cities like São Paulo, where I am now. Our capital is Brasilia, where the Ministry of Health and the government is located. It is in the middle of Brazil, you can see on the map. And our official language is Portuguese. So I want you to try to look at this picture and try to guess who is Brazilian in this picture. Can you try to guess, Dr. Aya?
You know, I'm going to say everyone, huh?
Yeah, it's everyone. Yeah. So the thing I want to show to you is that the Brazilian is a mixture of different cultures, different colors of people, and we are actually very proud of it. So everyone can be a Brazilian. In this map, you can see the socio-demographic characteristics, socioeconomic characteristics and disparities in Brazil. So despite we are a big country of mixed people, we are also very different in terms of wealthiness. So we have like in green in the map, you can see the more richest people, I mean the global, the average per capita money. So in red, we can see the more poor places of the country. So they are located more in the north and northeast of Brazil. So we have the main cities and the more richest cities more in the south, and then the less inhabited lands, and we have Amazonia, we have some parts of northwest that the people are really poor. So these directly impact in the COVID-19 and also in all the disease. The social determinants of health, it's something that we have to take into account in Brazil as well, and also everywhere in the world. So we have a varied landscape from dense forests to a long coast face to the Atlantic, and the diversity that I told you before, where we have a mixture of religious, music, and all the aspects, culinary as well. So I was talking to you the social disparities in Brazil. It's a picture, famous pictures of São Paulo, where we can see Islam, a favela in the left, very close to very rich houses. So, and yes, we have football as well. So in Brazil, we have the unified health system. We call it SUS. The SUS is our universal health coverage. It was instituted by the Federal Constitution of 1988, which recognized health as a right of all and a duty of the state. So it is financed by the federal, state, and municipal government. So these three actors, governmental actors, they fund this huge universal health coverage system. It's indeed is the largest national health system in the world, and the only one that serves more than 200,000 inhabitants. So the SUS offers for free from primary care to complex procedures, from surgeries, emergency care, vaccines and medicines for diabetes, hypertension, asthma, and a great source of disease, malaria, HIV, etc. And it also funds research in epidemiology and public health. So it's a strong system, public health system. And also it provides surveillance on the quality of food, natural resources, air, water, soil. So we're not facing a good situation in Brazil regarding to COVID-19, but it could be really worse if we don't have our public health system. So a short timeline of COVID-19, we can see, sorry, because it's in Portuguese, but the first case, reported case of COVID-19 in Brazil, it was in the end of February. After 26 days, we reached 1,000 cases. And then after 14 days, 2 weeks, we reached 10,000 cases. And the cases steadily go up. It's very fast. In almost a month later, we had 100,000 cases. And then almost 2 months later, we had 1 million cases. And then a little bit more than a month later, we had 2 million cases. So as you can see, the cases in Brazil rapidly increased and really fast. So at the beginning of April, this is an expected number of deaths in the countries highly impacted with the COVID. Brazil is in this third one. So it was in April estimated that we could reach about 1 million deaths at maximum, but the minimum, it was estimated to be around 400 or 500,000 deaths. So it's quite a lot, but we are going through this number. I don't know, hopefully we won't get there, but it's a situation that worsens a lot. Here are the data from yesterday from the WHO website, where we can see Brazil in the second of the most cases in the world. It's considering now a community transmission. We are going from 600 deaths per day to a bit more than 1,000 deaths per day. So it's a really huge number. This is from Brazilian website. I took it today, where we have a bit more cases than these reported by WHO, and incidence coefficient of 16 cases per 1,000 inhabitants, and the lethality rate of 3.2. Well, I'm not gonna attach too much or lose too much time in these numbers, but see, you can here you can see the graph of the comparison of Brazil and other hard-hit countries. You can see United States, a very huge increase at the beginning, and then they seems to control it and facing a second wave. In Brazil, we had like a very steadily increase in the number of cases, and seems like we at the moment almost 2 months after the beginning of the pandemic, we had a stabilization. Mexico comes almost in the same graph, a bit later than Brazil, and then went a bit up, and then it's changing a bit. So in this graph, you can see also is the same data, but as I told you, Brazil remains stable since May. But the problem is that is a huge number of cases and deaths. So we are seeing a stabilization in the disease pattern at the moment in Brazil. But the problem is we stabilized in very high numbers. So this is the lethality rate in some countries in Latin America. Just a quick comparison. Brazil has 3.4, used to have in 8 August, now is 3.2, the lethality rate in Brazil. It's more than every country that we compared here, not only in Latin America, but we have Uruguay and Chile and Argentina in Latin America, Paraguay as well, the one, and also when we compare to South Africa or to New Zealand or Australia, we're still higher than all of them in lethality. How can we explain this stabilization in higher levels in Brazil? The COVID-19 starts from bigger cities and metropolis like São Paulo. It the first impacted city in Brazil, and then the cases starts to spread a bit in closer distance until it went far to the interior of Brazil, the more distant states in Brazil, the north and northwest. So this graph shows at the left bar, you can see São Paulo and the bigger cities. And then as you go to your right-hand side, you can see the smaller towns. So you can see at the beginning, the red line is the bigger cities. And then when we go to the right, the blue lines are the smaller cities. So you can clearly see that the pandemic starts to go from the big cities to the small towns, and it happens very, very fast. Today, all the municipalities with more than 20,000 inhabitants have at least one case of COVID-19, and almost all of the more than 5,000 municipalities in Brazil have cases as well. So this small graph on your right-hand side is the distribution of the COVID deaths by states in Brazil. We can see São Paulo state, which is the most populated state, the leadership of this run, followed by Bahia, Rio de Janeiro, Minas Gerais. So it's just to see that every state we have cases now. But some are worse than others. Here we can see the cases by the municipalities in Brazil. We can see a lot of cases in the south area, where I show it to you to be the richest parts of the country. But when we see the incidence coefficient, we can see that it affects more the poor places in Brazil, and more to the north and the middle of Brazil, and a bit less in the south. But even so, it's highly affected as well. So these are deaths and mortality coefficient. It follows the same pattern. When we see the deaths, also it is distributed more to the most populated places, and also the capitals in Northwest state, Manaus as well, in Brazilian Amazon up to the north. But when we see the mortality coefficient as well, we see the same pattern. It goes from the most dense and populated cities to the poorest places. I think Adeilson will talk a bit more about it, so I'm not gonna take too much time on it, but it's just to show you guys the difference between the number of deaths and also the mortality coefficient and the most impacted places. Here, we can see a comparison between the situation, the COVID-19 situation in countries with more than 100 million inhabitants. This data is from at the beginning of the August, and well, it's a good comparison because it shows the population, the tests, number of tests used, the number of cases, the number of deaths, and also the coefficients, the incidence coefficient, the mortality, and also the testing. So as you can see in this picture, and we can see Nigeria as well, it's just to compare. So we can see it's lesser impacted than Brazil. And also you can see Brazil has way less tests than India, United States, Chile, and Australia or South Africa. And a lot more cases, not comparing to US, but the others. So when you see the indicators, the incidence and mortality, we're doing pretty bad as well. When you can see, we're not testing a lot. So it's something that, in my opinion, we have to improve because testing can help us to understand the disease distribution, but it's still a limitation for us. Well, this one I'm going to show you now. It's a preliminary results from the Brazilian Ministry of Health. Is a non-published data. So I'm gonna briefly talk about this. I can't show a lot, but at least to give you some clues about what workers are the most impacted and how it is affecting the states in Brazil as well. So the Brazilian map here on the left-hand side, we can see one important thing is that our notification system, it doesn't allow us to put occupation, to register the occupation of the cases. So we've been negotiating it with the official system, but we're having some trouble to get this on. But as the occupation is not stated in the notification system, a part of the health health workers and security workers, which is included. But we don't know by the cases and by our official notification system, we don't know who are these cases in terms of occupation. We don't know the most impacted workers, and we don't know where they are more impacted in terms of location. So what we did, we took the identity number of this database and we make a linkage with the employment database. So by the identity number that every person has in Brazil, we linked it with this employment database. And we were able to get the occupation and the economic sector of these cases, the COVID cases in Brazil. So these are preliminary results. We analyzed this database up to 30th July. And this map, you can see the incidence coefficient and also the number of cases as the larger balls represents the number of cases, and the colors the incidence. So what we found preliminarily in this data, we found that the highest impacted economic sectors were the public administration, defense, and social security. Some of the health workers, they are also listed as public administration, because, for instance, they work for a public hospital, so they are listed in this first line, public administration. But we had more than 200,000 cases between these people, which represents 28% of the cases. The second highest economic sector affected is the trade, even retail and wholesale, and vehicles repair. This sector was closed at the beginning of mostly closed at the beginning of the pandemic, especially those selling, for instance, clothes and jewelry. The shopping centers were closed, but the supermarkets were open. They didn't close at all. So a lot of cases come from these workers. The third one, we had the human health and social services. When you see in number of cases, they were the third most affected professionals. But when you see the coefficient, the incidence coefficients, they were the highest. They represent the more risky occupations. Well, we have the manufacturing system, the administrative activities and constructions all going on. Education, they're quite low because they still mostly closed and doing remote. We had a total of cases in this analysis of more than 840,000 cases. The mean incidence coefficient in these workers are 15.6, and in population in Brazil is around 16 per 1,000 cases. So the most affected sectors, just to briefly shows the public security, as I said, ranging from 39 to 52 cases per 1,000 workers. The meat plant workers. So we had some problems. We're still having some problems in Brazil in the meat plants. The environment, the work environment, it's something that raised our concern, because people normally in this meat plant, they work very close to each other in this production system, the plants. So also they share the places to eat, sometimes to sleep. They normally come to work in full buses, so as a transportation. So it's some characteristics, some risk that we can see in these meat plants. The petrol and oil workers, they normally also work remotely, sleeping together, a lot of people, and so on. The steel industry as well, 28 cases, the meat plants, 32 cases per 1,000. So it's almost double than the general population, the risk of among these people. The food and beverage industry, so these represents basically the occupations that didn't stop at all in the disease. So our concern now regarding the workers is that as this disease spread mainly for the workers who didn't stop, now as we are returning, our concern is about the disease spreading to these workers that were at home, mostly in quarantine or at least in isolation. So the health workers, our frontline heroes, they are very highly affected. One thing that call our attention here is that when we see the economic sectors of the health workers and social services in Brazil, we have most of cases not related to emergency and intensive care. We have 52% of the cases not related to emergency services, where we expected at beginning to be the highest impacted sectors of the hospitals. So 52% happens of the cases in those workers happens in hospital services, but not in emergency care. As the emergency care and intensive care respond to about 18% of the cases. When we see the incidence coefficient, it's another very interesting numbers, because we can see the highest incidence coefficient among those who play support activities in the hospital. So what I want to call your attention here is that these people are normally less well prepared. They are normally they use less PPE, which are the protection equipment, and because they don't feel that they are directly exposed to the virus, they work in a hospital, they protect less, they have a lower risk perception about this disease, and they not every time they don't know how to protect themselves, so they are at a higher risk. Well, the occupation, the nurses, and are the highest one. The physician and the general practitioner as well, very high, almost the same coefficient. And the nursing technicians and assistants as well, they are very high. So what we have here is some of the professions, the health workers that we have to care the most. We also have the physical therapists, mainly those developing some activity in the intensive care and at the hospitals, and the health promotion and support services, and also the technicians from the labs and blood banks. So these numbers showed us that these occupations, they have relatively very, very higher risk compared to the general populations or formal workers. So I'm gonna briefly talk about this notification obstacle. Starting from the up to the bottom, we have like sick people in the population, the number of sick people in the population, and then lesser people manifest any symptoms. Today we have numbers varying between 20 to 30%, going up to 60%. I've seen in some papers. But it's still numbers are changing, that part of the people are not symptomatics. They are asymptomatics, and they could probably transmit the disease as well, being symptomatic. And then we have less people who are symptomatic and seek the health services. From those who seek the health services, a part of it are clinical evaluated, and a smaller part of it has their sample collected and analyzed for exams. Even a lesser part of it has received their results, and then a small portion of these people from a broad range of people who get sick are notified by the system. So the real burden of the COVID-19 is still unknown. And it happens not only in Brazil, but all over the world. So we are discovering new things and discovering the real burden and the impact of the disease as the disease are going on. So our main challenges, I want to briefly share with you a quote of a colleague that I heard that is really interesting, where he say, to cope with a public health emergency, you don't have to do the same things you do faster. You must do different. So it's something that I want to lead to you to take in mind. Our main challenges, this is my personal opinion of this COVID-19 in Brazil, is that a new disease represents a new challenges. It's something that we are not used to, so we are discovering things as the disease are going on. So it's something that we have to take in mind. A big country like Brazil means that we have big problems as well. So as larger is the country, as bigger are the problems. So the third challenge is the lack of structure and resources. For instance, in some countries, especially those in the north and northeast, we don't have too many hospitals. We don't have too many intensive care. We have a shortage of protection equipment as well. So in a big country like Brazil, but I think in Kenya it happens as well, these problems of lack of structure and resources impact us and compromise our response. The lack of preparedness as well. As the disease was new, we don't have protocols to treat it. We didn't know the right way to face the disease. People, the workers, and not only the healthcare workers, but also the general population, they have they're not trained to respond to this pandemic situation. So especially in the beginning, we are struggling to face it because we're not prepared at all to face this pandemic. Another challenge as well, and it's still a big challenge in Brazil, is the discrediting and miscommunication. We didn't have unity in the communication. We at the beginning, and our politicians, they are facing this disease as a little flu or something that must pass very fast. We're gonna get hit anyway, so it doesn't matter how we react to this disease. We're gonna get hit anyway. And it compromised a lot our response, and is still compromising our response, I believe. So as earlier, you can show the public makers and the policy makers that this is a disease of a huge concern. As earlier they realize that, I think it's going to be easier to face the disease. The sixth challenge that I can point to you is to treat different realities in the same way. So in Brazil, we have a federal government and we have the state governments. The state governments, they also has power to determine, to make rules and everything. But what we have in Brazil is that we try to treat the same thing whatever we're talking about. So that was a big mistake in my opinion. So what is a real challenge here is to treat different realities differently. So it's something about equity, where we realize what the necessities, what the needs of the territories, and treat them different, to give to them what they really know to face this disease. The seventh, it's something that we're facing now and is worrying us a lot, is that the people got bored about the COVID-19 and they're trying to force the back to normality. So it's something that we are really worried about, that the cases are still going up, but we are trying to push the way back to the normality. And where should we go, just to finish this? The first thing that I could tell you is that the COVID mantra, we're not doing it so good at all. I think it must be improved in Brazil and also in United States. But the COVID mantra is identification, isolation, testing, contact tracing, isolation, testing, contact tracing, identification. So what we have to do is basically identify as soon as possible the people who has the disease. The symptomatics they are the easier one, but also the pre-symptomatics who has contact with somebody confirmed for COVID. We must isolate these people, both the confirmed cases and the suspected cases, because they can easily transmit the disease in their communities. We have to test, and we must test more in Brazil, and we have to develop contact tracing tools that are able to, even before the people manifest any symptoms, we have to be able to contact to trace these contacts, to find them, and to isolate them as well and test. Well, we still have to foster our capacity to respond. We are the Ministry of Health at the moment developing a lot of materials, a lot of training courses, a lot of guidelines, a lot of epidemiological analysis, as I showed before. And we are publishing protocols and updating them continuously. That other thing that you have to have in mind. We did some protocols at the beginning of the disease, and we had at 1 or 2 months we had to review them. We have to update them. Another thing that we should do now, it's providing supplies, keep providing supplies and improving the structure, especially for giving the states more respirators, the more protection equipment, giving them more tests, and not only giving them more tests. As I said, the federal government is a richer actor of these public sectors in Brazil, and can give it to the states and to the municipalities. But also we have to share with them the right way to use it and the best way to manage them. Another thing that I regret that Brazil didn't do really well at since the beginning, and maybe it can help you as well, is making a risk matrix for the disease distribution. These matrix, they can be state, by towns, by neighborhoods, by economic sectors, and then this risk matrix can go from the lower severity, where the situation is pretty not much worse, where we can open a bit more and better regulate these sectors or these towns regarding to the risk that we are facing at the moment. I think Adeilson will talk a bit more about it. So another thing that we have to work on it. Is the community transmission the disease? What is the difference between the community transmission of the disease, the COVID-19, and the work-related disease, the causal relation of this disease related to work? For instance, just a quick example, in a hospital that serve people with COVID-19, the reference hospital to COVID-19, when a health worker are contaminated, I can clearly see a causal relation of this exposure at work. But what about a store, a chocolate store in a shopping center? Well, as this worker are in the community, goes to the supermarket, goes to the church, can I assume this case was work related? So this is something that we are trying to clarify at the moment. We are discussing it a lot internally in the Ministry of Health. So we are still don't have answers for that, but we are working on it. And the last thing is always make science-based decision, evidence-based decisions. So this is a quick view of the matrix risk, the medium, low, and higher risk, but I think Adeilson will tell a bit more about it. Yeah, I think that's all. Muito obrigado, many thanks. Nini. I don't know if I tell it right, but I tried. Okay.
Yeah. Thank you very much, Dr. Rafael.
For the moment.
Yeah. No, thank you very much for that presentation. I think that's a really good comprehensive overview of what the situation is and especially some of the challenges. There's some comments on the chat, and I'd like you to look at that. And after Dr. Ribeiro presents, then we can come back and give about 5 minutes to answer that. And if there's time, we can do a bit of oral questions as well. So I'll invite Dr. Ribeiro. Just to go right ahead and present. And then we can have some time after that just to answer some of the comments that are being made in the chat. So for participants, if you have some comments, please, I think it's better if you put it in the chat and we can continue to answer those as well.
Good afternoon. Thanks for the invitation. I'm very happy to stay here with you, to join with you to show some particularity related to coronavirus infection in the state of São Paulo. I will share my presentation now.
Yep, we can see it.
Yeah. Everybody can see my presentation?
Yeah, we can see the presentation, yeah.
Okay. I'm Adeilson Ribeiro, I'm PhD in Public Health, and as you said in the beginning, and now I am postdoctoral research at Barretos Cancer Hospital, and I work mainly with the science of geographic information, applying it in the epidemiological field. I will show the geographic distribution of COVID-19, the northwest region of the state of São Paulo. The topics that I will follow in this presentation, the roads for COVID-19 importation in Brazil, the COVID-19, the metropolitan region of São Paulo, the process of spread the disease for the whole state of São Paulo, the context of COVID-19 in the 5 regional health departments. I chose it because I work in this regional health department. I geocode the new coronavirus case in this region. Because of this, I have some maps to show in my presentation, explain about the disease mainly in Barretos City. And I will conclude this presentation showing the São Paulo State's action plan to deal, to handle with this pandemic situation. I would like to show my presentation with this, the result of this, this work, roads for COVID-19 importation in Brazil. This work was published in the Journal Travel of Medicine. You can see here one map and two graphs. The A map, the map shows the map, the Brazilian federal states and the federal districts classified by color according to COVID-19 notification status in the beginning of March. Suspect, confirmed, confirmed import and local, only imported, no notification. And the size of the circle classify the data according to the estimated proportion of importation from COVID-19 destination. The graphic B is possible to see the proportion of the passengers from affected countries, and C, the estimated of the COVID importation. In the next slide, it's better to understand, to see. And this work concluded that around the 55% of all imported cases would be expected to come from travelers infecting Italy, and around 9 and 8 of the cases would be from travelers infecting China and France, respectively. As Rafael said in your presentation, the first case in Latin America was confirmed in February 26, in the São Paulo metropolitan region. The route Italy-São Paulo was estimated to comprise around 25% of the total infected travelers flying to Brazil during this period. Here in this map, I show the São Paulo in red, São Paulo municipality. All the colored areas is the metropolitan region of São Paulo. Guarulhos Airport is very close to São Paulo and is the biggest airport of Brazil. This airport is responsible for the majority of the flights that arrive in Brazil. And the new coronavirus arrived here, the first case, in this metropolitan area with this estimated population. The municipality of São Paulo, according to the last estimate, has around 12 million of inhabitants. The entire metropolitan region of São Paulo has around 21 million of inhabitants. Imagine the virus start to arrive in this density area. For idea, for example, in the last census tract, 2010, 10 years ago, the demographic density for São Paulo was around 7.5 thousand of inhabitants per square kilometers. 10 years ago. Imagine the situation now. The people used to circulate, the circulation of people in this area is very, very intensive because the commuting travel. People used to live in the metropolitan region, but go to São Paulo. People go to São Paulo and come back to home every day by bus, by subway, by cars. And this process of people circulation is very, very intensive. and the new coronavirus arrive in the middle of these high density areas. Because of this, this context that I showed, in June, it's possible to see some weeks after that the new coronavirus is spread for the whole metropolitan, for the whole municipality and the whole metropolitan region. Which point here is related to 3 cases. Some dates are in Portuguese, but it's possible to see here that the virus is spread very fast for the whole metropolitan region of São Paulo. In the middle of the pandemic situation, started the social isolation process, but only working activity that is impossible to necessary activities. But I think there are many situations that the people need to go out to work, and because of this, the rate of social isolation remain around the 50%. Is not so high because the goal is that the rate achieves 70%. It's contributed a lot for the infection. Here is the map of the São Paulo state to know the whole state. In red, the municipality of São Paulo, and the state of São Paulo has 645 municipalities, cities with high density population, medium density, and the low density. Is very heterogeneous. The area is around 248,000 square kilometers, and the estimated population is around 46 million people. I think is the state that has more people in Brazil. Very density. Spread in the state following the main roads that cross the whole state. The incidence start to increase in cities placed near these highways. The traffic is very intensive in the meaning of capital and the cultural side in the 2 ways. Because of this, the COVID-19 first start to appear first in the cities near this, and after the disease start to spread into all the municipalities. Rafael already said this map. I already showed this map in his presentation, but I would like to highlight here with this circle the state of São Paulo, the current situation now. It's possible to see that the COVID-19 is already spread for the whole state. When you look more, when you see closer, it's possible to see here that you have regions with more than 1,000 cases, and the regions with 100 from 100 to 1,000 cases. Very heterogeneous. It's related to the size of the municipalities, the size of the population. São Paulo, the São Paulo state is divided in 17 regional health departments. that help the government to deal with the public health in the state. And I highlighted here the 5 Barretos because I work in this area, in this health department, and I will show the evolution of the disease, the COVID, in this department, focus on Barreto City. Here is the 5 regional health department of Barretos that include 18 municipalities. Barretos is the municipality that when the coordination of the regional health department is placed. In the estimated population of this region is around 440,000 inhabitants. Now I will show the evolution of COVID-19 in Barretos. The first case in Barretos arrived 20 days after the first case was registered in Brazil. Here in the first epidemiological week, from 19 to 25 in March, it's possible to see that 4 cases appear in the city, 2 cases in the same address. The third epidemiological week of COVID, the number of cases increased from 4 to 25, 13 new cases in the same week, and the disease started the process of spread. In the 5 epidemiological week, the number of cases increased to 63 new cases. New cases now here. The new cases is colored by the confirmed case in red, new cases in black. I prepared this map for the epidemiological surveillance for the municipality of Barretos, and I highlighted the cases, the new cases, to help the epidemiological surveillance to detect the places when the disease, the new cases are appear. 7 epidemiological week of COVID-19. Here, I would like to show this heat map related to this epidemiological, sorry, I need to come back here. I would like to highlight that this map is related to this epidemiological week. Now you can see areas with high density of case. In the small circle, it's possible to see the downtown area, and the big circle is above the neighborhood around the hospital, because Barretos has a big hospital. It's a reference in cancer treatment. This hospital is attracting people who look for health care from different regions of Brazil, from northwest, from different people across the whole country to arrive in this city looking for treatment, cancer treatment. Because of this, I really realized that the circulation of people here in this circle, in the big circle, had great importance, because this neighborhood received people from different regions of Brazil. Here is the Barretos Cancer Hospital. Is as I said, is the main reference center in cancer treatment. And this map is possible to see the heat map, the heat map for COVID, but it's only for the cases included in this epidemiological week, because in the other map that I already showed, the heat map is related to the total case, total confirmed case. But now this map is only for this new cases that occur in this epidemiological week. And it's possible to see that the COVID-19 is spread not for the peripheral areas, is the same pattern that occurs in São Paulo and the other cities, other countries. First, the cases are used to be detected in the city center, but after the epidemic started the process to spread for the peripheral areas. And now you can see high rates, high density are areas with high density of cases in peripheral areas. Here near the hospital, because I said that this neighborhood will receive people from different parts of Brazil. Because of this, is a region that is very need more attention for the epidemiological surveillance. This the geocoded case related to the first included case only until the first day of July. And now you can see that the COVID-19 spread for the whole city. Here I have the total case, but now the number of cases is almost 3 times more than this. The case increased almost 3,000 cases. Now I have almost 1,000, but with 1,000 cases, it's possible to see that the whole city has an intensive process of infection. I show the situation for Barretos, but the same patterns occurs in the 18 municipalities of the regional health department, the 5 regional health department. Barretos has some particularity that I said, because the hospital and because comparison to other municipalities, Barretos has been made more tests than the other. Because of this, the number of confirmed cases is higher. Because Barretos has a laboratory, molecular laboratory, inside the place in the Barretos Cancer Hospital, that is helping the surveillance to detect new cases in the municipality. Because of this is one reason that the case is so high in comparison to another that I will show in the next slides. But here you can see that even in the small municipalities like Terra Roxa here on the right, or medium size below here, the city below, all the urban area has a lot of confirmed case. Here's the other, I highlight the other part of the regional health department. Here in the up, in the left, I have a medium-sized city. In the middle, a small city below. But in all the cities, it's possible to see a lot of confirmed cases by COVID-19. The current situation, in this moment, the current situation, the 5 regional health department has around 5,000 confirmed cases. You can see here the first Barretos, Olímpia, Guaíra, and Bebedouro. the first 4 cities in this graph with the high number of cases. This city has, I think, bigger population in comparison to another, but is an explanation because the cases is higher. Yeah, but I think Barretos, when you compare Barretos with the others, Barretos has more cases. Even when you compare the population, the proportion, Barretos has more cases in comparison to other municipalities. The population here, the estimated population for the 5 regional health departments. Here, this graph shows the total case confirmed in Barretos in blue, and the orange, the 17 municipalities, the other 17 municipalities that compose together with Barretos the 5 regional health departments. As I said, I'd like to highlight again, I really believe that there are 3 points that are contributing to high number of confirmed cases in Barretos. 2, I already said, is because the number of people from different regions that arrive in Barretos every day looking for treatment, for care assistance, for cancer. The other reason is because the number of diagnostic tests that has been done in Barretos is higher in comparison to the other municipalities, and because the social isolation. I think in general, Barretos, the rate of social isolation remain around 50%, the maximum 50% during the whole the epidemic emergency, and the goals of the state is to achieve 70%. But here I have data for the São Paulo, the total municipality, the total state. The state of São Paulo records nowadays around 27.5 thousand deaths and 721,000 cases of coronavirus. I have contextualized here only the situation for 5 regional health departments, because as I said, I geocoded all the cases for the public health system to help them. But it's possible to see that even inside these 5 regional health departments, you have a lot of the diversity related to the size of the population, related to the availability of the bed for intensive care unity. Only consider 1 regional health department, and I show that São Paulo has 17 regional health departments. Imagine the diversity of the situations that the state needed, that the government needed to handle with this epidemic emergency now. And I only showing the situation from São Paulo state, but Rafael said the diversity in Brazil is so big, and it's very difficult to handle with this infection in a big country with continental areas. Now I will show the São Paulo state's action plans, because you need to São Paulo needed to create some measures to handle with this diversity, heterogeneous situation, and because of this, this action plan has, what can I say, is defined by stage of economic recovery in the state of São Paulo. And it's divided in 5 phases. Phase when because the municipalities, in general, the municipalities are classified in red, in orange, yellow, green, or blue. And for example, in the phase 1, maximal alert, contamination, high contamination phase, with release only or release of essential services only. For example, drugstores, supermarket, gas station, only essential services is allowed to be open. The intensity of protocols is high for phase 1 and decrease in direction to phase 5. For example, phase 2, the orange, phase of attention with possible releases. In this phase, I will show the criteria in the next slide to classify, but in this phase, it's possible to release some business with some protocols, some measures to apply safety for the activities. Applying safety for the activity, to achieve safety. The phase 3, flexibility. Control is a control phase with greater release of activities. I will show the next slide, all the activities, what kind of activity that is possible to be open in this phase. Phase 4, partial opening, decrease phase with fear restriction. And phase 5, disease control phase, release of all activity with protocols. But the protocols here is smaller, very, very small in comparison with the red phase. So activities that will receive flexibility. Sectors will be prioritized according to economic and employment vulnerability. For example, here I will show the criteria for phase calculation. You have 2 criteria, health system capacity and pandemic evolution. The result of the classification is a combination of the 2 criteria. The indicator, for example, the health system capacity, you have 2 indicators. Bed occupancy rate for intensive care unit for COVID. For example, if the municipality has above 18%, and for example, here, the second, beds of intensive care units for COVID divided for 100,000 inhabitants. I have 2 indicators for health system capacity. The combination between the 2, you classify, you said in what phase the municipality will be included. For example, maximum alert, above 8% of bed occupancy rate for intensive care unit. And this relation, the rate here for beds and for the population, if this rate is below 3, the municipality will be classified in this phase. But the second is related to pandemic situation. For example, here, of new cases, the number of new cases in the last 7 days, divide of the number of new cases in the previous 7 days to evaluate the intensity of the infection. Or number of new cases in the last 7 days, divide of the number of new admissions in the previous 7 days to evaluate the intensity of admission in the hospital related to the infection, because the symptomatic person, And the third here is the number of the deaths by COVID-19 the last 7 days divided of the new deaths by COVID in the previous 7 days. And I have here the categorization that the government applied to use it to classify the areas. But here, for example, for health system capacity, consider the bed occupancy rate for intensive care unit to achieve, for example, phase 3. The rates need to be the rates need to be between 17 and 16. Only below 60%, you achieve the partial opening, the phase 4. The second, the next slide, I will show here the opening of the sectors of the economy according these phases. For example, here I have the thematic sectors on left, and the phase, for example, in what phase this sectors is possible, is allowed to open. For example, public space, only phase 5 is allowed to open. Real estate activities in phase 2, but open with restrictions. Car leadership, phase 2, open with restriction. Offices, open with restriction phase 2. Bar, restaurant, and similar, only phase 3. Only phase 3. So only, for example, São Paulo has a lot of bars and the restaurant in the whole state, and this in general these activities remain closed for the last 4 months, because now I will show in the next map increase the number of areas, municipalities that are in this phase yellow. Trade in the phase 2, open with restriction. Shopping center, phase 2, open with restriction. Beauty salon, phase 3. Gym, phase 4. Theater and cinemas, phase 5. Promotes event and general crowding, that promote events that generate crowds, including sports, for example, only phase 5. Education, phase 5. In this moment, there are a lot of discussion about the educational, because there are some municipalities that would like to open the school, and the others would like to remain it's closed. You have the example in the United States that the number of infection in children achieve high percentage after the return to class. And because of this, I think in Brazil, the education, the school, you want to open in September, but sometimes October, I don't know, but I don't have, I believe that sometimes it's impossible to open this year without vaccine. And the transport to be defined. And I will show now 3 evaluation of São Paulo State. The first evaluation, in the middle of this process of the evaluation, and the last evaluation that was released last week. For example, here is the first evaluation in June. You can see here that São Paulo, the municipality of São Paulo, here in the middle of the red phase, because São Paulo, the municipality of São Paulo has high rate of bed for care, intensive care. The number of beds is high in comparison to the other municipalities. Because of this, São Paulo was classified in the orange phase. But in the metropolitan region of São Paulo and the south of the state were classified in red. I think the majority of the areas around the state in the regional health department was classified in orange, with some areas in yellow. When you move for 1 month after, 1 month and a half after the 5 evaluation in almost the middle of July, you can see the intensity. It's possible to see the intensity of the process of spread of the disease for the countryside, because it's possible to see that the situation became better in São Paulo and the metropolitan region, but the majority of the state now was classified in red area, with a lot of restriction, with high intensity of protocols. Only necessary activities were allowed to work. Here is the last evaluation. This evaluation was released last week. You can see that the situation in general became better for the state, because a lot of regional health departments now were classified in yellow. It's possible to open, for example, bar, restaurants, but with a lot of restriction. For example, the use of the masks, sometimes the time that the activity needed to work. But in the north of the north of the state of São Paulo, in Barretos, that I showed, that I contextualized before, remain in the orange, with on the side you have the Franca region with red. And the south of São Paulo state has a regional health department that remain in red situation for the entire evaluation since the first until now. It's a difficult area, but it's a poor area in the state of São Paulo. Yeah? This area is not a rich area in comparison to the north. Because of this, I think the situation here is worse in comparison. It's more difficult for this area to change for a better phase. And you need to stay in the same phase for 14 days, and you have evaluation, and it's possible to advance or not. It's possible to come back to our situation according to the criterion that I explained before. I will finalize my presentation with I think with the main highlight the main challenge for the São Paulo state now. I think the main challenge for the São Paulo state now is to classify all the regions in green and the blue phase, because you can see São Paulo it's impossible to see region with green and 5. You only the better scenario that the municipalities achieve is the phase 3. No areas in phase 4 and 5. I think in the next month, sometimes in October, it's possible to see some areas in phase 4, but I don't know because the number of cases beside the situation became better in some region, in others the situation became worse, and because of this, in the average, the number of cases declined, remain declined of the curve. It's so difficult because it's difficult to handle with the situation. I show only for example, the situation of São Paulo. But for example, when you compare the size of the land, it's possible to put, for example, inside the São Paulo state, six Netherlands inside the São Paulo state. And I only explain about the situation of São Paulo with a lot of diversity. Imagine the situation in Brazil when you include all the states with a lot of municipality with high diversity related to socioeconomic status. It's so difficult to handle this situation. Rafael said, showing in his presentation, the diversity in Brazil, but here it's possible to see that even when you focus in a small, in a specific area, it's possible to see that there is a lot of diversity inside too. Thanks for your attention. My mail here, adeilsonribeiro@gmail.com. If you have some questions after related to this presentation or this plan in other moment, it's possible to send me an email, and I'm very happy to answer the question. Thank you very much for your attention.
Yeah, thank you very much, Dr. Ribeiro, for that presentation. I think when the presentation, and particularly the last bit there about the size of Brazil and the complexity of what we're dealing with, is very, very informative. It's been very interesting, and what I'd just like to suggest as we close is to just give Dr. Chris Baraza a moment to just summarize some of the questions and comments, and then we will ask for like a 1 minute from Dr. Rafael and Dr. Delson just to close, and then we'll hand back over to the team at KNH. So, Chris.
Thanks, Richard. Obrigado, Ribeiro and Rafael. That was quite very wonderful presentations there. So, Rafael, you just 3 clarifications that have been common across the questions that we've had. And one of them was, you mentioned that the general hospital healthcare workers seem to have been affected more compared to emergency healthcare workers. This was a question that was raised by Bashir. Probably you could just give a bit more insight into that in terms of what do you think could have led to this as an observation? Because we work in a hospital setup, Kenyatta National Hospital, and we have different probably mechanisms or preventive modalities that's put in place. So probably just some insight into that. I would probably ask you the 3 questions, and then you can respond to all of them before I ask Ribeiro his 2 questions. The second component that touched on your presentation was, and this was asked by Chemwei. Chemwei is our infection prevention control lead at the Kenyatta National Hospital. So she's basically, of course, concerned about the healthcare workers and how the infection has affected them. So she was asking the criteria that you are using in Brazil for the healthcare workers to come back to work, and whether there is any aspect of stigma that you've noted as the healthcare workers come back to work. So probably just a bit of talk around that. Then the third last question that I wanted to pose to you, that was actually asked by Peterson, is whether there are any special regards that you've given to the healthcare worker who may be at a higher risk in as far as the infection is concerned. And he mentioned some of the potentially higher risk healthcare workers like pregnant women, the elderly. Are you giving them any special considerations? Are you giving them on preventive medications, or are you starting them on preventive medications, for instance, or are you giving them time off from work for the period of time that the coronavirus is there? And for how long are you doing this? And to what extent is that affecting the service delivery at the hospital, at the hospitals where you are working? So Rafael, probably you can go just respond to those before I ask Ribeiro the two questions that I have for him.
Awesome. Many thanks for these questions. I've tried to answer some of them by the chat. So I also give my email, so everyone who wants to further discuss any of these topics can reach me out. The first, I will start by the last questions, how to protect the health workers at a higher risk. So what we did is, since the beginning, we recommend all the hospitals to remove these higher risks to home work. So they're basically working remotely. They were not working at the hospital. And especially pregnant women and elderlies and people with chronic disease, we are strictly recommending the hospitals to send them to work at home. And how did we balance this shortage of professionals? We ask the people, the students from the last year of medicine, and it was agreed with the Ministry of Education to start working and following, as those people mostly are younger than these high-risk professionals, so they were able to, under experienced professional supervision, they were able to help facing this situation. So basically, we remove this high-risk work from working at the hospital inside. The other question was, what my clues for the why hospitals workers, the general hospital workers, were more affected than emergency workers, if I understood well. And my opinion, we didn't have any study on that yet, but my opinion is that the emergency workers, they were more prepared to face these situations. They were more trained to higher risk situations. And also, especially at the beginning of the pandemic, we had a shortage of supplies in PPE, for example, the protection equipment, and we prioritize these emergency care workers to this. Assuming that they will be more exposed to the virus, but yeah, we got surprised when we saw that support workers and administrative workers were highly infected as well. So we try to reduce these disparities along the process. And the last question, it was about the resumption to work. How did they were able to become the infected health workers to become reinsert to the work again. And we are currently discussing the new situations and possibilities based on the specialists' experience in field. And we just came out with a new decision map for when to remove these workers from work, and when to resume and when to put them back. And basically, when some health worker is symptomatic, we try to test, and if test positively, we remove them from 10 days. And we are able to resume them to work if they are without any symptom, when without fever, for 24 hours. We are basically using the same recommendations as CDC, the the Center of Disease Control in United States, but also I'm happy to share these, reach me out by email and I'm happy to share. With someone at the hospital have symptom but test negative, we remove them to work, but reassume them, when also they are at least 24 hours without any symptom. In case of if we don't have tests available, what we do is we remove them to work, and again we allow them to go back to work when they are 24 hours without symptom. So basically is that. And also we are recommending a quarantine for closer contactants and domiciliary and residential contactants. Yeah, I think time is over, so I can give more details by message. Thank you.
Thank you so much, Rafael, and thank you so much for giving us those elaborate answers on the question and answer chat wall. I know we could not be able to exhaust everything, but I just have a summary of 2 questions that Ribeiro will be able to probably just respond to. And one of the questions that has been asked is, did you notice any spike in the incidence of COVID-19 when we had the FESIC, because you demonstrated that you've been reopening the country in phases. So did you notice any increase in the spike or rather the spike in the incidence of COVID-19? And what are some of the community strategies that you put in place for you to prevent this from happening? And just quickly, in line with that, is we as a country are grappling with the idea of, should we open schools or should we not open schools? How has been the experience in as far as reopening of schools and colleges? And is it something that you've seen or experienced a spike in infections, especially in children and college-going students, in case that has already happened? Thank you. Ribeiro, you can kindly unmute because you are muted.
Sorry. Yes, as I said, I show in the planned action, the education is only for the last phase. I think with the transition between the first 3 phases is a way that it is possible to open some activities, but in this situation, you have a high infection. I think it's very difficult to open the school, to handle the situation related to school now in this moment and until the end of this year, because I think there are a lot of children in social isolation with any contact with the virus. When these children enter in contact with other children inside the school, the infection will increase more. And because of this, when the children come back to home, you infect the parents and the grandmother, grandfather. I think the situation of the open school is very difficult to handle this year. I think only, in my opinion, only after the vaccine. I think there is a plan in Brazil to open the school now in September, with the half of the population of the children inside the school, and they have remain with online classes and change it, switch it during the week, in the following weeks we change, sometimes at home, sometimes at school. But I think that the situation, I can see it happen in the next month, for example. I don't know, because the rate of the infection remain remain high in Brazil. You can see that the rate of infection is high. Sometimes the phase became better that I show because the availability of the bed for intensive care unit, but not sometimes for the infection.
Yeah, thank you very much for that, Dr. Baraza. Yeah, so I think we've come to the end, and there are lots and lots of questions. It's been a very interesting presentation from Dr. Adelson and also from Dr. Raphael. I'd like to just thank, first of all, John Kiragu, together with the Health Policy Group, the MPH students in the Health Policy Health Systems Group in the School of Public Health, for inviting Dr. Adelson and Dr. Raphael to come and present to us today. And of course, we're together with Dr. Chris Baraza at the School of Public Health. And we're running a blog, so kenyahealthsystems.org. So we will ask to get some of the stuff that is there. I think there are lessons that we can pick up and apply to our country as well. And I'd like to thank Dr. John Kinuthia and Rhoda as well, the KNH group, for hosting us. And I'll hand back over to them now so that we can just close, and maybe they'll tell us about the next presentations. Thank you very much for taking time to present to us. We're very, very happy, and certainly we have learned so much that I think that we can apply. So thank you. Rhoda?
Thank you, thank you, Dr. Aya. Thank you, Dr. Baraza, and thank you, John Kiragu. Thank you, Dr. Ribeiro, Dr. Raphael, for the presentation. We apologize to the rest of the participants for going a bit overboard, but this was totally necessary. I've enjoyed both presentations and I've learned quite a lot, and I'm seeing we have similarities in challenges, so thank you so much for highlighting that. I'd like to appreciate all the participants who attended today's session and wish you a good evening. Thank you very much. And we hope to see you tomorrow in the morning session, where we'll be sharing our experiences in managing COVID-19 disease in various counties. I'm seeing quite a number of questions. I'd like to apologize to the participants who were not able to tackle your questions, but I hope you picked something. The recording will be available. To the participants who raised their hands wanting to ask a few questions, we apologize. Time was not on our side, but I hope you've picked something from this presentation. So have a good night, and thank you very much. God bless you. Bye.
Bye-bye. Thank you so much.
Bye-bye.
Thank you very much.
See you in another
Thank you very
opportunity.
much.
Yeah.
All right, thank you.
Bye.
Thanks for
Thank
the
you very much,
opportunity.
Dr. Raphael, Dr. Adelson, Rhoda, everyone. Thank you.
Many
Thank you.
thanks.
Bye-bye.
Bye-bye.
Many
Thank you.
thanks. Bye-bye.